Okay. Okay, good morning, everyone. My name is Elizabeth Leone, and I am the chairperson of the New York City Local Early Intervention Coordinating Council. I would like to welcome you to our second web-based LEICC meeting. As of May 15, 2014, New York City's local law number 103 of 2013 and the New York State open meeting law require open meetings to be both webcast and archived. This meeting is being recorded today. A review of the procedures for the LEICC meetings. For in-person LEICC meetings, attendees should pre-register on the New York City Department of Health Early Intervention LEICC webpage. For web-based LEICC meetings, attendees will find the link on the New York State or City Department of Health Early Intervention LEICC webpage. Meetings are open to the public, but the audience does not address the LEICC members during the meeting. For this web-based meeting, we will not be using the chat or the Q&A features. For this web-based LEICC meeting, members of the public were asked to submit written public comment by email. Public comments will be read into the record at the end of the meeting. LEICC members will raise their hands instead of raising their cards to make comments. LEICC members should keep their cameras on during the meeting. Transcription is available for this meeting. Written meeting minutes will also be available. LEICC members, would you please introduce yourselves? Where should we start?
Yeah, I'll start. Lydia Ledniak, Assistant Commissioner of Bureau of Early Intervention.
Hi, I'm Roseanne Saltzman, and I'm sorry I can't get my camera to work here, but I am the director at Up We Grow. Good morning.
Good morning. My name is Simone Hawkins. I'm the Assistant Commissioner for the Bureau of Child Care at New York City Department of Health and Mental Hygiene. Good morning.
Good morning. I'm Sonu Sangui, Clinical Director at Achieve Beyond.
Good morning. I'm Mary McCord. I'm the Director of Pediatrics at Gotham Health, part of New York Health and Hospitals, and the clinical lead for an early childhood project called 321 Impact, which I'll talk a little bit about today.
Hi, good morning. I'm Chris Trieber. I'm the Associate Executive Director for the Interagency Council.
Good morning. I'm Kara Chambers. I'm the Director of the Legal Aid Society's Education Advocacy Project.
Good morning. I'm Trish Pico, Chairperson for the Committee on Special Education, New York City Department of Ed.
Hi, good morning. I'm Sundari Periyasamy, Pediatric Co-Residency Director at Harlem Hospital.
Hi, everyone. I think that's everyone. Okay, so now Assistant Commissioner Ledniak and I would like to introduce a new LEICC member and an LEICC member taking on a new role. So the first member I am happy to introduce is Patricia Gray. Patricia Gray holds a doctorate in education and leadership and is a licensed clinical social worker. She has over 30 years experience providing services in mental health, child welfare, homeless services, supportive housing, addiction services, and in academia. Dr. Gray's experience and educational qualifications allow her to provide an array of social work services that include but are not limited to clinical service, supervision, training, staff development, and supportive case management. Dr. Gray is currently the Interim Director of Continuing Education at the Silberman School of Social Work at Hunter College. Dr. Gray currently represents the Silberman School of Social Work on the Academic Preparation and Professional Development Subcommittee of the LEICC. Welcome, Dr. Gray.
Thank you. And I believe we just had Yuri join us. Yuri, do you want to quickly introduce yourself?
Sure. Good afternoon or good morning. We're still in the morning. My name is Yuri Pawlik. I'm an Associate Commissioner at the Administration for Children's Services. Good morning, everybody.
Good morning. Thank you for joining us. Okay, and I would like to introduce our new chair of the Local Early Intervention Coordinating Council, Elizabeth Leone. I am very happy that Liz agreed to take on this role. Elizabeth Leone is a mother of 3 sons, one of whom received occupational therapy and speech-language pathology services beginning in early intervention, which continued through his school journey. Ms. Leone has a bachelor's degree in the CUNY BA program of Unique and Interdisciplinary Studies, concentrating in speech-language pathology, early childhood education, and child psychology. She is currently pursuing her master's degree in early childhood education with an early childhood special education extension at Brooklyn College. Since 2020, Ms. Leone has been a co-lead early childhood teacher at the Brooklyn College Early Childhood Center. She has educated and nurtured children from 4 to 48 months old, including children with developmental delays, and supported their parents. She mentors Brooklyn College early childhood undergraduate students during their fieldwork placements, coaches student teachers, and is a research assistant conducting qualitative interviews with Black and Afro-Caribbean infant toddler teachers regarding their knowledge and experiences with early intervention. Before this appointment as chair of the LEICC, Liz was a parent representative on the New York City Local Early Intervention Coordinating Council. Please welcome Liz to this new role. This is her first time really taking the helm, and I am so pleased that we have a parent as the chair of our Local Early Intervention Coordinating Council.
Thank you, Lydia. So now we will approve the minutes from the last LEICC meeting. May I have a motion to approve the minutes?
I motion to approve the minutes.
Thank you. Can I have a second motion?
Second.
Thank you. Sellers, can you take a vote, please?
Yep. Okay. Good morning. Kara Chambers.
Approved.
Trisha DeVito.
Approved.
Simone Hawkins.
Approved.
Elizabeth Leone.
Approved.
Mary McCord.
Approved.
Yuri Pawlik.
Approved.
Sundari Periasamy.
Approved.
Roseanne Saltzman.
Approved.
Sonu Sangoe.
Approved.
Christopher Trieber.
Approved.
Lydia Leniak.
Approved.
Thank you.
Thank you. So the motion carries and the minutes are approved. Now we will have the Assistant Commissioner, Lydia Leniak, present on the SEICC report, the update on telehealth evaluations, and the COVID-19 EI program update.
Thank you, Liz. All right, so the first item for the report will be the State Early Intervention Coordinating Council, which happened on September 24th. The EICC agenda items are there before you. As usual, we have circulated all of the presentations from the State Early Intervention Coordinating Council for your review, but I will be highlighting 3 items for you today. The first will be broad early intervention administrative updates. The second will be the work of the provider work group on capacity. And the third will be implementation of the EI Hub, which, as you know, will replace the New York Early Intervention System, NICE, as early intervention's primary case management and billing system. Okay, as far as administrative updates, the state provided an update on their teletherapy guidance. Obviously, as you all know, teletherapy services and evaluations continue to be available through the COVID-19 pandemic. Consent for teletherapy is still required, and group services may not be provided utilizing teletherapy. What you will be interested to know, which was a big topic of ours last time, was the June 30th, 2020 transition accommodation was in fact granted, which thank you for your advocacy in terms of council representatives and other folks in the community that allowed for early intervention to extend children in early intervention until August 31st, who were due to age out on June 30th because they hadn't had completed evaluations or there were some other process alignment issues. The other update that was given, obviously, was the state issued guidance on reopening of group services, which I will talk to you about in more detail in the next couple of slides. As far as teletherapy going forward, at this point, there is no rate set for teletherapy after COVID-19 until the State Department of Health issues guidance. However, the State Department of Health, as well as the Early Intervention Coordinating Council at the state level, approved for teletherapy to become a topic for guidance development for the Provider Capacity Subcommittee. So I think it's safe to say that teletherapy is moving in the right direction in terms of becoming one of many available service options in EI, though we're not there yet. The other update that was given that I thought was important to talk to you about here today and clarify a couple of points is around transportation. What you may not know is that the way transportation services are paid for in early intervention is different than the way that, say, other services are paid for. Transportation services in early intervention are reimbursed as an administrative cost, and the state, at the request of the Centers for Medicaid, are changing that to a fee-for-service reimbursement model. What that means when you step away from all of the bureaucratic minutia is that municipal governments stand to lose a lot of money by this modification and policy, okay? And that is really because not every child in EI has Medicaid, and it impacts all of those downstream reimbursement issues. However, this is obviously useful information to you from an advocacy standpoint, but it will not affect the on-the-ground delivery of transportation services to children, nor will it impact reimbursement to providers. However, it impacts the municipal government's ability to do its job. With that, the state is making provisions for the use of the Medicaid Transportation Manager, whereby children who are Medicaid eligible will be able to access transportation services to programming via the Medicaid Transportation Manager. And this obviously involves a big new process that needs to be rolled out with a lot of requirements and considerations for service coordinators, early intervention officials, et cetera. However, we are not in New York City at the point of implementing that right now. The state needs to first issue this policy guidance to the municipalities, and then the municipalities will implement them. So while you see the date in front of you set as November 1st, I believe that hopefully we might get the guidance on November 1st, but then it will take us time to actually figure out how this is going to impact our system, and we're going to want stakeholder feedback on that policy guidance ultimately. So I want to pivot. Sure.
My question is, for kids who don't have like a specific medical need for transportation, like a mobility impairment or something, does that mean that they will no longer be eligible for transportation to and from EI center-based programs, or just that the municipality will have to absorb the cost?
So the answer to your question is they will definitely still be eligible for transportation services, regardless of who pays, right? That's something that we have to deal with on the back end. However, in terms of Medicaid, the Medicaid Transportation Manager, it is only an option that will be obviously available to Medicaid eligible kids. However, that doesn't mean other options won't also be available. So this is just adding another transportation option to the available menu of choices, if that answers the question.
Yeah, thank you.
Can I comment on, if this is, I'm not sure this would put you in the same boat as the kids who are coming in for medical appointments using that Medicaid manager, but that system is hard to use. For medical appointments, you really do have to have a significant disability. You have to ask for the transportation in advance, and they just instituted a new rule that you can't do it across boroughs or at any distance without a secondary approval. So you need two approvals. You need one approval for the transportation in the first place, and then a second form and a second approval that takes a second set of days for it to cross borders. So I'm not sure you'll be completely in that same boat, but it's a problematic system from the family point of view, and it is work for the providers to get all the pieces of paper in order.
Yes, thank you for that feedback. I mean, that is our understanding to some extent. However, we are going to have to really figure out how early intervention as a system can intersect with this option. And so that is why we've been getting questions from the provider community about, should we start doing this? Should we start figuring this out? And the answer is not yet, because we as a municipality have to examine this first. So thank you for that. The next thing I just want to pivot over into is a report on the Provider Workforce Capacity Task Force. And really, the original charge to the Provider Capacity Task Force was to work on issues of provider capacity. And at the last SEICC meeting, there was a recommendation made to reduce the number of hours necessary to become an early intervention provider, and to offset it with some kind of broader training requirements. At the last SEICC meeting, obviously in response to the committee members' request to also include teletherapy within the scope of the Provider Capacity Task Force charge, a number of things have happened. So first, the Provider Capacity Task Force has, there's a little background noise. Thank you. Several of the subcommittee members proposed foundational core competencies for the delivery of early intervention services and evaluations in the early intervention program. And these competencies really are intended to serve three purposes. The first is to develop required trainings for department-approved early intervention providers across all disciplines to support and supplement education, training, and experience requirements. to support the early intervention workforce to seamlessly transition from telehealth to in-person service delivery to ensure access to services and supports, and to serve as recommendations to guide pre-service graduate curricula across all disciplines to build capacity, effectiveness, and the effectiveness of the workforce. And I think these don't really look new to you. We have been presenting on these competencies for the last 5 years. And so we were happy that they were utilized as the foundation of the state's competencies. At this point, the next phase is for these competencies and all of the supporting literature and evidence to be reviewed by the State Early Intervention Coordinating Council for ultimate approval by the New York State Department of Health for this to become a guidance document and basically requirements for the early intervention system. We're obviously really happy about that because nothing like this exists right now, and we have been working on this with our academic partners and providers for several years. So we are happy to see this moving forward. The next charge for the Provider Workforce Capacity Task Force is to develop an evaluation of teletherapy. And so we, as a municipality, were also able to submit the surveys that we have developed that will be implemented in New York City for statewide consideration. We are obviously aware of the fact that from a state perspective, this is going to have to get modified, but we are happy that some of the information will be considered. So the last sort of state update that I would want to give is an update on the EI Hub implementation. Since March 2020, the state has conducted virtual focus groups, developed functional and technical specifications for the system, and began demonstrations. What is coming up now will be, there will be another readiness assessment that will be sent out to early intervention providers and stakeholders, so please complete it if you are in a position to, because the state very much does use that information, and it also then uses the people who complete it to draw upon for various focus groups. So and user acceptance testing and training efforts and things like that. So it is very important for everybody to complete it. There will be user acceptance testing once the system is ready. In New York City, we have volunteered, obviously, to do all elements of user acceptance testing for the new system. We will be drawing upon provider leadership and other stakeholders to test to make sure that the system works as it should. And also the state is going to start making training and other resources available. Key implementation dates that are very important for everybody to be aware of. That is the launch of the case management system is slated for spring. Gosh, it's so close already. Spring 2021. There will be a cutover period between NICE and the EI Hub of 2 weeks. We have to still determine what that is going to mean for us for those 2 weeks. If NICE will not be accessible for a 2-week period as the system cuts over, we need to understand how we are going to continue to function and perform our case management activities during this blackout period. So the go live date is scheduled for May 2021, and NICE will remain in a read-only status until September 1st, 2021. And then at that point, it will be decommissioned. So what I want to say is this. If there are any attachments that anyone needs to get out of that system, you should start now. You should make sure that all records for children that you've had are complete and you have them somewhere tangibly, whether it's in an electronic structure, whether it's in a paper structure, whatever it is, but eventually NICE will be in a state where it is decommissioned, and you will not be able to access any of the attachments in that system. Okay. I want to get through the rest of the presentation, and then we'll take some questions. So an update on our telehealth evaluation. We are done. The surveys are ready. Thank you for all of your review and feedback. We are going to be doing telehealth evaluations of families, therapists, and agency administrators. There will be 3 of them, and they will provide insight into families and therapists' experience with teletherapy and the training and resources that all of these unique groups of individuals need in order to effectively implement telehealth in New York City as an ongoing thing, not just on an emergency basis, if you will. So we are obviously formulating a distribution strategy. I think that we will be coming to many of you to get more of your ideas. Primarily from a parent standpoint, we will be utilizing text to families. We have 17,000 families subscribed and texting with us all the time, so that will be a good way for us to get a lot of family input. But it will be very important to ensure that we have a good amount of therapists completing this, and we don't really anticipate issues with agency administrators completing this, but I think it will be very important for us to get a good amount of therapists completing this from various disciplines for us to get all of the various perspectives. I want to shift over and talk to you about the COVID-19 program modifications that continue to evolve. I feel like it's important to show you all where we've been so that we kind of have a grounding for where we are, because so much has happened in the last 7 months that it's pretty amazing. And I mean, I just think that the system has been doing an excellent job shifting and adjusting itself in order to deal with all of the various changes. So in March, New York State deemed the early intervention program as an essential service during New York on pause, meaning that we continue operating. As of March 24th, we fully shifted all EI services in New York City to be delivered utilizing telehealth exclusively. On June 22nd, in response to the state's issuance of early intervention reopen guidelines, we issued a detailed plan for New York City resuming in-person services. And this approach emphasized and continues to emphasize flexibility and the understanding that it might be necessary to shift between in-person teletherapy and between in-person and teletherapy services based on what's going on in the communities and various health metrics. And I think we're seeing that now. So this is what the reopening has looked like for us. Phase 1 implemented June 8th, Phase 2 June 22nd, Phase 3 July 6th, which allowed for the reintegration of home-based and individual-based evaluations to be delivered as in-person services. Phase 4, July 20th, and SDOH provided guidance regarding the opening of EI groups that they could restart 30 days after the first day of school, which in New York City means October 21st, which we are approaching. I put up the slide last time, but I feel like it's important to reiterate this, that early intervention providers have been doing an excellent job in putting systems into place to ensure that all early intervention services are delivered in a healthy and safe way. These precautions include face coverings, physical distancing, hand hygiene, additional controls on toys and materials, as well as increased cleaning, disinfecting, and ventilation, and also various required consents and screening protocols. Where are we now? We are approaching October 21st. We obviously, in our fashion, we have issued a pretty detailed and lengthy guidance document about resuming in-person group services. Group providers are very excited and anxious to start delivering in-person group services. Bus transportation will be available as of the first day of EI groups. So thank you to our DOE partners for that. In order to support in-person, home-based, and also group services that we are about to start, we have released a detailed COVID-19 case reporting requirements document. And it outlines what providers must do and what they must submit to us when there is a confirmed case of COVID-19 in a group, home, or community-based setting. And thank you to Simone for her partnership and assisting us to develop this protocol and document. And what I will say is, yes, we have been getting reports. And we haven't been getting many reports, but there have been some. And I have to say that providers are doing an excellent job. And the health department is doing a great job also to manage these situations and ensure that we are very effectively shifting to teletherapy services in certain instances. And I envision, and this was kind of good. It's giving, we started slow because it was only related to in-home services, and now the same protocol will extend to group services. Finally, which is something that we have all been dealing with for the last week and a half. I mean, it feels like longer. So the governor announced the COVID Cluster Action Initiative, which has outlined 3 zones, red, orange, and yellow, with restrictions within each one to reduce increasing COVID-19 infection rates. This initiative mandates that in-person activities within the zone be reduced to the level of New York on pause. Because of that requirement, it has put early intervention in-person services in the red zone back to teletherapy for a minimum of 14 days. Remember what we talked about a little bit before. In the restart plan, everybody has been stressing from the beginning, it's very important to talk to families and make sure that we have both sets of consents on file, both the restarting in-person services as well as the teletherapy in case we need to shift back and forth. And this has really been a test of that. And I will say that most of the families, or many of the families affected did have consents for teletherapy on file. And so it was, some of that sort of seamless shifting did happen. So this has also obviously had an impact on the restart of groups, because group providers in the red zones will have to delay their opening dates until the COVID rates are under control. Okay, questions? All right. Liz?
Okay. So now we'll hear from Nora Puffett, Director of Administration and Data Management. She'll be reporting on the data report and update on provider oversight activities.
Good morning. So I know that everybody wants to hear about what's been going on since COVID, but we wanted to keep you up to date on everything. So we sent the LEICC our full traditional report this week, as well as the COVID pre and post. But I wanted to include here today this one slide from the more what I call traditional report, just to keep our eye on the big picture. And it's really what everyone's concerned about, which is what are referrals looking like and what's the impact. So I want to remind you that the fiscal year in New York City is July 1st to June 30th. So the April, May, June quarter there is what closed out 2020. And you can see that it had a big impact. The number of referrals was about 17% lower than it was last year and really the 2 years before that. And that's not surprising when we look at the next slides about just the absolute number happening in those months. You can also see that the first quarter of this year is, if it were to continue, would put us a little lower than traditionally. But obviously, that really is going to depend on what happens with COVID in the next few months. Next slide. So getting back to the real focus on COVID, this is the weekly activity, referrals, multidisciplinary evaluations, and IFSP meetings from January, well before this all started, until the very end of September. And what you can see here is that, unsurprisingly, what was least affected was IFSP meetings. A lot of those were existing children, and they were able to happen virtually, which meant we had almost no cancellations. And so they only started to go down when the impact of having no new referrals really, and thus no new initial IFSPs, really started to kick in. What you can see with going on in this last month or two, though, is as referrals are going up, the other two are kind of falling right behind, right? So as you have more referrals, it's going to take a little while to see the impact on MDEs and then a little while to see it on the meetings. So you can see there's that lag, but all of them are really heading back up. Next slide. So this is taking the same data but comparing it to last year. And of course, I think this may be of most interest to people. And what you can see there, the gap, the dotted line above is 2019, and the bars below are this year, and the gap in between is what the drop-off was. Just like on the previous slide, we see that IFSP meetings, not such a huge impact. Referrals, had the most dramatic impact, and then MDEs had a more drawn-out impact. And I think that had partially to do with both MDEs pre-COVID coming in during the COVID period, and then also the challenges around learning to do teleevaluations, which usually took longer. But you can see clearly that most of them are really getting close up to where they were last year. Next slide. And this is that same data by race, which we're really trying to focus on, as you know. And I just want to put out there that all four of these are on the same scale. They go up to 350 here. And so your immediate thought is, oh, that it's much more dramatic for white and Latinx children, but that's just because they have more absolute numbers. Actually, the change wasn't so different. It was more significant for Black children. But for all of them, the drop-off at the worst point for referrals was between 80–86% across the groups. Next slide, please. And this is MDEs by race, pretty similar. And then, next slide, please, is IFSP meetings. And so we've lost control of the slides.
We have lost control of the slides.
Hang on a second. Can you hit just like arrow or something to see if it works?
We're having a little bit of technical difficulties. Charles, are you here? Can you assist us with, we're having some issues with our slides.
Yeah, right now you're the presenter. Do you want someone else to be the presenter?
No, I can't advance the slides at all.
Or on the left-hand side of the slide screen, you see an up and down arrow?
Nope, it's gone. Sorry, everyone. Give us a second. Can you switch the presenter and then make me the presenter again?
Yeah, let me try that.
Thank you. Okay, there we go.
Again?
Yes, we are good. Thank you. All right, Nora, were we here?
Yeah, I think we were.
Okay.
So the bottom line with all of these is keeping in mind that September always has a bit of a drop because of the Labor Day weekend and also the Jewish holidays. It does look like most of our areas of activity are pretty much getting very close to where they were in 2019. And if we were to continue like this, I think we would probably see consistency with last year, if not even a little bit of an uptick. But as I said, we really don't know what's going to happen in the next few months. So we'll have to wait and see for that. So next slide. So we showed this last time. It was for the first time because normally we don't share really operational details. But we were sharing this because we thought it gave you some insight into how things are moving through our system during this time. And so what you're seeing is that in terms of number of days from referral to us getting the MDE continues to be elevated. It's nowhere near what it was, but it's definitely more than it was pre-COVID. And again, I think part of that is the lag that we're still seeing, like tele-evaluations come in, and we're also seeing the impact of referral drops. So that I expect to go back to normal, but it's clearly going to take a little bit of time. In terms of the decrease in the number of days from the evaluation to the initial IFSP meeting, this is comparing us to 2019, and because it's negative, it's telling you that we're actually taking fewer days, we're going faster. And while we're not seeing the level we were in May, which was probably partially because there were simply fewer MDEs and initial IFSP meetings, we are good, and we're actually not only a bit better than January, we're a bit better than, that means, last year. So that piece of the process, at least, and which is really interior to EI ops, that is still really going pretty quickly and pretty well. So overall, I would say that most of the indicators are that we're on target to get back to where we normally would, with the understanding that there's that first quarter, is just always going to be much lower. I don't think we're going to see a huge influx of referrals that would normally have come in July. We're probably going to just stay on track. So do folks have questions? Great.
Thank you. I'm sorry.
I couldn't find the raise your hand feature. I'm sorry.
So the raise your hand feature is on if you click on participants, and then there's a little hand.
Oh, okay. I'm sorry. Okay.
Do you have a question though? Go ahead.
Yeah, I just wanted to ask, on one of the slides that was sent to us, the children receiving any type of service from July 2016 to July 2020, and the numbers between fiscal year 2019 and 2020, there's about a $5,000 person difference, children difference. So the fiscal year that's in that 2020 is from July 1st to June 30th?
Yes.
So that kind of means that basically the COVID impact was really March, April, May, and June, but so a lot of those numbers change within those 4 months?
Probably. That's a good question, and we'd have to actually break out that data. We haven't looked too much at that, but yeah, I think there's a likelihood of that.
Okay, yeah, because that's a lot of kids who have not been identified. And
yes.
Probably will be identified at some point in the future in terms of service systems.
Yeah. Mm-hmm. We were talking about this the other day, and the question really is that if there is a missed opportunity in EI because of COVID, right, which there obviously was one because families may not have been going, to the doctor, or their visits with their doctor were different, and so maybe there was less, whatever, maybe something wasn't caught, or there was a lack of follow-up somewhere along the lines, and also if children were not going to childcare, and we know childcare is another place where, issues are identified and then conversations happen with families, and so with the children being at home, right, yep. It creates it creates less of an opportunity to, access various systems. And the real question is, will they access the 3 to 5 system, or will we end up seeing a break all the way until 5?
Mm-hmm. Yep. Okay. No, thank you.
Thank you. Okay, so now we'll have Mary McCord, Director of Pediatrics at New York City Health and Hospitals, Gotham Health, and Catherine Canary, Medical Director at the Bureau of Early Intervention. They will be presenting on improving referrals and bidirectional communications with H&H and the COVID-19 testing recommendations.
Thanks a lot, Lee. So I've actually been part of EI for 5 years, and we've been talking about improved bidirectional communication between the program and healthcare providers since I got here. But we particularly started talking with Dr. McCord and others at Health and Hospital since spring and summer of last year, talking about referrals to EI and improved tracking in the healthcare system of what happens after the referral so that the primary care provider can participate in following up and, being involved with the family if the family doesn't agree to take up the referral or something happens with the evaluation. So this has evolved into an electronic health record-based referral form in Health and Hospitals electronic health record, which is called Eicc. There's also a parental consent to allow this bidirectional information sharing between early intervention and the primary care provider at Health and Hospital. So I'm going to let Mary McCord talk in more detail about the funding. She alluded to the 123 Impact Project. Anyway, I'll let her talk in detail about the funding and the piloting of the project and what it actually looks like.
Thank you. Let me know if you can't hear me. I have to lean very close to the computer. Sorry if you're seeing my nose too much.
We can hear you.
Okay.
And tell us when you want me to advance the slide.
Okay. So basically what the situation was that we're a health system, so we're looking at what can we do as pediatric providers, pediatricians, nurse practitioners who are seeing children for primary care in particular. I'm a primary care pediatrician. This I'm about to describe will be available to the NICU, the neonatal ICU, and other places, but the focus is on primary care. We have been talking for a number of years about working to focus the primary care in the early years on the social emotional development of children. Of course, we would take care of all the medical problems that come up, but there are not a lot of them. And most of what we do is counsel parents and support them. And we got some funding from the Robin Hood Foundation, and then it was matched by New York City Health and Hospitals and a little bit from the mayor's office in order to really make this a systems change effort that's starting in 3 of the Health and Hospitals primary care pediatric sites, Queens Hospital, Souvenir on the Lower East Side, and Bellevue in Midtown in Manhattan. And those 3 sites have been very interested and focused on early childhood care for a long time, so we chose places where we thought we could have good success. And we're implementing a broad program that is offering support for families, including programs you may be familiar with, Reach Out and Lead, and the Video Intervention Project, and something called Healthy Steps, and care coordination services, so that when we identify a problem, we can, whether it's a problem like a need for early intervention or a problem like a family that's about to be evicted from their home or they can't put food on the table at the end of the month, those kinds of problems. We now have care coordinators available at these sites to help families address needs that we identify, and we're doing more formal screening so that in addition to the work we have always done of meeting with families, talking to them, and having a dialogue with families about what they feel their needs are and how we can help them. In order to not miss problems, we're adding to that structured screening. And one of those is a structured developmental screen, which is recommended by pretty much everybody now that pediatricians do this. So at every visit, we talk about development. And at every visit, we have a dialogue with the family about how the child's doing, how the family sees the child's development, how we see the child's development, and any advice we have to offer. But to back that up, we're also starting to do validated structured screens, like there's one called the SWIC, there's one called the ASQ3, and we're doing those screens at recommended times, 9 months, 18, and 36 months. This is just starting the structured screen part to get off the ground. In thinking about that, we realized, and I think we can go to the next slide here, that we needed to think about the process when we find a problem, whether through structured screens or through our interviews, of effectively making that referral to early intervention. And the current state before this system is that the provider has to understand the basic process of referral. They have to find the piece of paper that's the early intervention referral, and they might have it in a folder, or their colleague might have it in a folder, or they might have it in a computer folder. They have to print it out or take it out of the drawer. They have to fill it out with the family, all those details, the name and the address and mom's date of birth and the hospital of birth and various things. It takes about 5 minutes to fill out the form. And then on that form, as you know, there's a consent for sharing of information that allows us to get information back. We faxed that off to early intervention, and we didn't have any way to track what happened later, next, except to note it in the record, and when the child came back, the family came back, we could talk to them. And we still do that, of course, when the child comes back, we talk to them, but we wanted to have a more systematic effort to make sure we weren't missing things, that people weren't forgetting to address it at the next visit, or kids that missed a visit, we might forget to follow up with the family. And so we started to think about how we can, because we're doing everything, as I guess you are too, in the computer these days, how we can take advantage of that to get the referral out more effectively. And through the funding we got for that early childhood project, we were able to get funding to work with our electronic record, which is called Eicc, and to build a process where we can now, there it is, to do the referral in Eicc instead of on paper. So we work with Lydia and with Kathy and with others on the team, Nora, to make sure that what's on this is what's going to come out of the computer when we do the computer referral. This takes a little bit less time because things like my name, the address of my practice, the child's name, the child's address are pulled in automatically. We would then type in the information that's not pulled in, particularly the reasons for referral and any other field that is necessary. And then from Eicc, from the computer, we can fax it, do an e-fax to the correct borough office. And this is, because our flow is so computer-based, this is going to make it easier for us to encourage providers who really haven't got the knack of making this referral themselves to do it. Many sites do refer to the social worker or to somebody like that to make a referral to early intervention, but when you do that, you lose more than half of the patients who don't make it to the social worker, the referral doesn't get out. You really want the referral to happen at the time the provider's having the conversation. So this is what the workflow looks like. The PCP, the primary care provider, through the process of screening and conversation with the family, identifies a child who is potentially delayed or who has another qualifying condition for early intervention referral. They then discuss that with the family, and if the family's in agreement, they begin the process of making a referral. And they fill out that form on the computer. The consent is now separated out as a separate piece of paper, so because we have to get the signature on it. And so we print that out and talk to the family about why we think it's important to get that information back. And we make a note in the referral order that this was done. The end result of this is that every child who's referred is flagged in the computer, and that whether or not they have consent for sharing of information is flagged in the computer. And this is going to enable us, and we haven't started this because we're just rolling out the process of referral. We can now take a look monthly or more frequently if their volume is enough, and say who were the 10 or the 20 kids at my practice who were referred last month we're going to make, we haven't developed the specifics of this yet, but we will soon. We will send it over to the early intervention team as a list. These 10 people were referred, and they all have consent. Can you tell me where they're at in the process? When we identify families who refused, told us that they were okay with the referral, but then refused to have the evaluation done, or families that they were unable to reach, we're able to complement the outreach, talk to the families about the reasons for the referral again. It is, we don't always succeed the first time we try at communicating in a way that people understand what the purpose of the referral is. But we have a broader team now. We have community health workers who are more peers and sometimes better able to communicate that kind of thing. So we think this is good, and this is going to allow us to see, are we referring at the expected rate, and are we referring everybody? So we don't have great data on race and ethnicity, but we're going to track that and try and improve our data, which we're trying, there's other initiatives to do that. So we can look at whether there's racial disparities. We can look at whether Gouverneur has a better or a worse rate than Sydenham in Harlem, where I'm practicing now. And if Gouverneur is worse than Sydenham, then what are the best practices at Sydenham that we might transfer to Gouverneur? And within practices, we can look at providers who, if they're providers who are consistently referring, they understand the system and they probably understand the purpose of early intervention referrals. If you have providers that never refer, it might be because they don't want to do that 5 to 10 minutes of work of making the referral, but it's more likely that they don't really understand something and we can work with them. So our goals here are to increase the number of referrals, to look at disparities in referrals, and to be able to follow up more effectively when families don't make the full connection to early intervention. Kathy, did I cover everything there? And does anybody have any questions? Well, the one thing we're pushing this at our 3 sites for this project where we have a little bit more staff, but once we establish the workflows and the best practices, all of the tools will be available to the director of the residency program at Harlem Hospital, who's on this call, and to everybody else. So we hope to roll out the whole program actually, but especially this early intervention referral process to the entire health and hospital system, and we take care of 75,000 children under the age of 5. So that's if we achieve our goal, then that's a lot of kids we can potentially help.
I just wanted to say how happy we are about this project and collaboration. I hope you can all hear me, because we think that this will really impact our system in a really positive way, because we know that there's a lot of missed opportunities within our program, particularly for the Black community, and we are hoping that partnering in this way with health and hospital system will really improve the equity issues within our system that we have been seeing since the beginning of the system. And, and we really look forward to continuing this collaboration and seeing it roll out to the entire health and hospital system.
Thank you. I have a question. Can you hear me?
Sure.
This is Pat Gray. Miss Mary, good morning.
Hi.
I am part of the academic partnership, and we're talking about ensuring that we identify field placements or internship placements for social work students and other allied professionals, including speech language, OT, PT, and others. And I was wondering, do you have social work students as interns right now that can assist you with the work that you're doing on the early intervention and making sure that we're okay?
That varies facility. It's very facility based. So if at Bellevue or at Gouverneur they have a social work team or individual social worker that develops a relationship with an institution, they might have social work interns. But in my experience, I'm not seeing social work interns with an interest in early childhood and who might be interested in this kind of thing. So that might be something that's worth talking about. It would take some time, I suspect, to work through the facility by facility processes that it would involve, but I'd be interested in talking about it, especially if it leads to students who have an interest in early childhood coming our way.
Absolutely. And also the bachelor level students are interested in care coordination and early intervention, so we can talk about it.
That would be great.
Absolutely.
Okay.
Dr. McCord, this is Sundari Periyasamy. I just want to commend you on this project. It's amazing. We have been trying to do this, to implement this kind of a referral system in Eicc at Harlem for the past year or so since Eicc rolled out. But we were not successful, so I'm hoping it will come to Harlem soon. And also, I want to mention last year, the residents at Harlem, their second year class, they did a project about it to see like how we can improve the whole process. But this is great.
And we could email me because you could roll it out at Harlem now if you have a champion, which it sounds like you would have. So I can explain more offline, but you could start now if you want to.
Okay, that's great. Sure, I'll reach out to you. Thank you.
Okay, I think we should move on. I'm sorry, we're a little bit on time. Thank you, Mary, for the presentation. And this is really great work.
So, as you may or may not know, the health department puts out health alerts periodically throughout the year based on current health issues like heat-related illnesses in the summertime or West Nile virus. And as you might imagine, there have been many, many health alerts about COVID over the last, many months. So there was recently a health alert around COVID testing, and there were recommendations for both diagnostic and screening testing, which are really not particularly different, but the target audiences are different. So diagnostic testing is aimed at testing individuals who have symptoms or have what's called a COVID-like illness, or individuals who have a known exposure to someone with COVID-19 in the previous 14 days. There's also a push to test folks who live in the hot zones, which have been recently identified, and particularly for individuals who have not had a positive test within the preceding 90 days. So there are a couple different types of tests that can be done. They're all antigen-based. One is called a PCR test, which is the gold standard. There's another antigen-based test. And these are, some of these are called rapid tests. And for a lot of folks who have symptoms or who have been exposed to someone with COVID and they want a result, ASAP as to whether they also are infected, then some of these rapid tests are really great. Next slide. Screening testing is for folks who don't have symptoms or who don't have a known exposure, but it is possible that they could be infected without symptoms, or they may be infected and going to develop symptoms, 2 days from now. And so the preference for testing these folks is with that PCR test. And again, the city has come out with some specific recommendations for folks who should get screening testing, not only those who have no symptoms and who don't have a known exposure, but there are several populations who are at increased risk because of their occupations. In the next slide. So particularly for EI folks, these might be, doctors, dentists, nurse practitioners, folks who work obviously in healthcare and dental settings, nutritionists, dietitians for EI, particularly OT, PT, speech, psychologists, psychiatrists, teachers, educators, and in-school support staff under the category of essential workers with frequent direct public contact, as well as social workers and childcare staff. So the recommendation is essentially folks who are providing services in EI should get tested every month or, more often if your healthcare provider recommends it. So the bottom line is, please get tested. And that's our final slide. Thanks. Any questions about that?
I don't see any hands raised. I guess we'll move on.
Yes.
Okay. Now we have Jeanette Dong, Director of Intervention Quality Initiatives, and she will be presenting on the Equity and Retention Focus Group findings and the Service Coordination Professional Development Institute.
Good morning. Next slide, please. Today I will be presenting a summary of the Equity and Retention Focus Group findings. In previous LEICC meetings, the Bureau has shared data that showed that Black families are referred to early intervention at a lower rate compared to the average rate of referral, and that Black families are also less likely to reach evaluations. Therefore, the Bureau decided to hold focus groups. One, to learn how to better engage and retain families in New York City early intervention by understanding the factors that influence Black family involvement in the program, by identifying the potential barriers to referral, and by determining areas of involvement needed. And secondly, finally, to learn how to be more effective in sharing information about early intervention with families. Next slide. So what was the composition of these focus groups? 6 focus groups were held in late February and early March 2020 by Zebra Strategies, a consultant group. 2 Black parents focus groups were held in Bedford-Stuyvesant and Brooklyn with 1 EI and 1 non-EI parents. 2 Black parents focus groups were also held in Harlem in Manhattan with 1 EI and 1 non-EI parents. In addition, 2 service coordination groups were held in Midtown Manhattan with 1 SC and 1 SC supervisor groups only. These reports provided anecdotal data and information and no numerical data at all. So how did recruitment happen? Neighborhoods were selected based on low referral rates to this program. In terms of the parent focus groups, EI parents were recruited through the Text to Families program. Zebra Strategies reached out and screened EI parents for eligibility that expressed an interest and consented to be contacted, while non-EI parents were recruited by Zebra Strategies based on their long-standing connections in the community. Service coordinators and SC supervisors were recruited by targeted email communications and phone calls to agencies that serve those families in the selected neighborhoods, and then followed up by Zebra. Parents and service coordinators received a small stipend for their time and to cover cost of childcare. So what were the barriers to enrollment? Denial. Black parents are least likely to seek help, especially if their child is young, because they believe they will grow out of any delays in development. Shame and stigma in the community related to disabilities and resulting isolation. EI families may not share with their relatives and friends that their children are in the program because of judgment and guilt. Lack of concrete knowledge about early intervention program. For example, some parents did not know that EI is provided at no cost to families in New York and that immigration status did not matter, while others thought EI was only for very severely delayed children. Next slide. Parent focus group members also shared that with some healthcare professionals, parents' concerns are sometimes ignored, dismissed, or minimized during pediatric visits. Some pediatricians did not take the time to fully explain EI, and this led to parents' misperceptions about the program. For example, parents thought that referrals to EI could only be made by pediatricians and other healthcare professionals. And then parents have to do their own internet research. Next slide. So in terms of retention, issues with therapists and service coordinators were found to be one of the biggest barriers. 1, parents feel that children are being overdiagnosed with attention deficit hyperactivity disorder and ASD. 2, the EI process is too confusing for non-native English speakers, especially for West African communities in Harlem and Caribbean communities in Brooklyn. 3, lack of collaboration and partnership. Many families felt that they were not being heard or listened to adequately when it came to scheduling and routines. Many parents preferred services to happen in the evenings or on the weekends when they could be available. 4, parents are worried that their children will be subjected to biases that EI providers from other races or ethnicities may have. 5, EI parents experience unreliable therapists that don't care. They do not show up on time or not at all or without prior warning to parents. Parents understood that when therapists refused their case because of bad parking, that meant that they lived in a bad or dangerous neighborhood. 6, parents will wait and switch agencies until they find someone, but in the meantime, time is wasted. Some parents will search for their own therapist by asking other EI parents. And lastly, some service coordinators call every other month to check in, but never ask parents how they're doing or whether they had any new concerns. Next slide. In terms of feedback from the service coordinators and the SC supervisors, the focus group included service coordinators that carried 15 or more cases. Most SC training focuses on administrative tasks and not about how to work with families. SCs feel that there is a real push and pull between paperwork for the agency and focusing on families. SCs also struggle with the shortage of providers who are willing to go to all neighborhoods, and many SCs live in the neighborhoods that the therapists deem unsafe. SCs spend a lot of time traveling, often spending 2 to 3 hours to and from during home visits, and they believe that they should be assigned EI cases in their own neighborhoods because they know the community. SCs want more effective supervision, better administrative provider technology, and more professional development training to help service coordinators to be better prepared. Next slide. The Bureau reviewed the feedback we received from the focus groups and began to develop solutions to address these barriers. The Bureau of Early Intervention, as part of the partnership with Hunter College's Zimmerman School of Social Work, is creating the Service Coordination Professional Development Institute, or the SCPDI. The focus of the SCPDI is to support service coordinators' engagement and retention of EI families with a focus on cultural competency. New York City Bureau of Early Intervention staff will also train SC supervisors with their service coordinators on how to run communities of practice. Communities of practice is an evidence-based method used across different fields to support changes in practices. Next slide. The SCPDI will focus on strengthening areas of practice that service coordinators and families identified as barriers to retention. The curriculum is currently being developed by Dr. Dana Crawford and Dr. Patricia Gray. Dr. Dana Crawford is a pediatric and clinical psychologist and an implicit bias expert that created the bias reduction theory and training. She has presented at 0 to 3 and other programs across the country about implicit and cultural bias. Dr. Patricia Gray, who all of you have met today, in her role as a director of continuing education at the Zimmerman School of Social Work, developed the curriculum and coordinated the early intervention training program that provided free continuing education courses on EI best practices, reflective supervision, and cultural competency with Rebecca Shimon-Chinook, Jonah Koji, and Tanya Spence. These trainings will focus on culturally relevant service coordination and use the focus group information for activities and role play to support greater understanding of implicit cultural bias in building relationships with families. It will also include case management and writing case notes, the role of family-centered practices in service coordination, and engaging and retaining EI families. So what are the next steps? The next steps for us are to share the training content with the LAICC Service Coordination Committee and the New York City Bureau of Early Intervention Race to Justice Group for their review. To also determine how the trainings will be performed depending on the status of the COVID-19 pandemic. And lastly, to notify the provider community when the trainings are available. Is there any questions?
We should think about a training for pediatric providers, since that was identified as a problem. We might be able to get residency program coordinators, for example, interested in something, especially if it's coming from families and people with a different perspective. That kind of interdisciplinary training would be something I'd be interested in thinking about it if anybody else is interested.
That sounds great.
I think that's an interesting idea. I think maybe what we ought to do is, I think, have you possibly also take a look at the training that is currently being developed. I mean, of course, the focus is on service coordinators. However, perhaps portions of it can be utilized, to sort of and reframed, because we don't want to provide something that may not be directly applicable or only partially applicable, but I think that's a really great idea. And I think what we should do is, once we get more into the H&H project and looking at what those data look like, we could then utilize that information to further inform who should get this training, potentially.
Yeah, we could start do it at H&H and see how it works, how it's received, what are strategies for getting it spread across different sites.
Sounds great. Does anybody else have any reflections on this before we move on to our DOE presentation?
I just want to say that I am so happy to see the collaboration, and I think from Mary and Catherine's initiative all the way down to what Jeanette is talking about, all together is going to help the parents. As a parent myself, I didn't have so much difficulty in EI, but I have encountered parents that have had those barriers, that did have those problems with service coordinators. So I think all of this together is really going to help, and I feel like it will bring up more referrals. So thank you, everyone. And with that, I'll continue on. We're going to hear from Caitlin Moore, EI Transition Manager, Division of Early Childhood Education at New York City Department of Education, and Avery Beck, Early Childhood Policy Manager, Division of Early Childhood Education, New York City Department of Education. And they will be presenting on Early Intervention Transition Initiative, the Document Transfer System implementation, and the DOE Early Childhood Updates.
Thank you so much. Next slide, please. So I will start by providing some updates on our EI transition work. I'll talk through our citywide information dissemination, an update on our EI transition coordinator team, and then our document transfer system as well. And Avery and I will then provide some general DOE updates with a focus on the nuances around early childhood education. We wanted to remind this group of a couple of initiatives of our early intervention transition work around citywide information dissemination. The first is a reminder that we have issued a second edition of the DOE guide to the EI to preschool transition. And we've updated this guide with a lot of new information from the first edition, which includes some updates with information on assistive technology, due process rights, an update on our FACE Center, Include NYC, information on health services available to families, and more information on least restrictive environment and the benefits of inclusion. This second edition has been posted on the DOE website family page and our public info hub using both of the below links, and it's translated in all DOE languages. And we've also printed the guide, and once offices reopen, we plan to distribute to all EI regional offices, as well as CPSC offices, and can partner with other organizations to send some guides their way as well. Based on this guide, we've also pre-recorded a webinar. This was based on some of our live info sessions that we started last January through March, that we obviously are not able to host live sessions right now. So we pre-recorded our overview for families transitioning from EI to preschool, and this is also posted on our Family Facing DOE website using the below link. And we are exploring opportunities to host live events for families virtually as well, and we'll provide an update to this group as we plan for those events. Next slide, please. So as an update, the EI Transition Coordinator team has transitioned from the Bronx pilot to a citywide team. So as of July 2020, our team is now no longer focusing on just working with Bronx families, and they now support families citywide. The citywide team has the same objectives as the Bronx team, and that is to support families through the transition from EI and to access services in the least restrictive environment appropriate for their children. The Citywide Transition Coordinator role acts as a resource to families across the city, and we focus on supporting the highest need families, like families who are in foster care, students in temporary housing, families with medical needs, etc. In this new role, the team supports children and families by responding to inquiries and escalations through an inbox and a telephone helpline. They also are starting to proactively conduct outreach to families transitioning from EI at key points of the year, and they talk about accessing preschool special education services and inclusive preschool options. They act as a resource and liaison between the CPSC and EI regional offices by having regular meetings with both of those teams, and this includes supporting the implementation of our new data systems, which I will talk about in a little bit. And in the future, this group will be providing some of those live workshops for families I was just talking about, and they will include information on inclusive preschool options and EI transition in these workshops. Next slide, please. So as a reminder, these are the ways that any service coordinator or family can contact our transition coordinator team directly. They can email us at ei2preschool@nyc.gov or call our helpline, which the number is up on the screen. And this is public and can be shared widely. So just a couple of, as a review, we wanted to reintroduce our systems terminology. So please feel free to chime in with any questions, because I know this is a lot of new terminology and a review since our last presentation with the LEICC. So as a reminder, our eFax and SharePoint system, we implemented eFax across all CPSEs and CSE regions to replace the traditional fax, and all fax numbers on the CPSE and CSE website are now eFax numbers. And so what this simply means is documents are still faxed, but they are uploaded directly into PDF form into a SharePoint system on our end. And this was initially implemented when we first went remote. So at first, this was open for use across the field, including EI, but now the only people who should be using eFax are those not authorized to use our document transfer system. The document transfer system is the new system of document transmission for EI field staff. And so this is where EI field staff upload and transmit documents to the DOE. And this is as of August 3rd. Next slide, please. So as a review, the document transfer system has replaced the fax for the EI field as of August 3rd. It's the new mechanism all EISCs must use to transmit documents to the DOE on behalf of the families that they support. This is a one-way document transmission service for all service coordinators. And so this is really just an electronic way to fax documents, or to transmit documents, I should say. The document transfer system is used by service coordinators to upload documents, input key child and family information to enable family outreach and prioritization by the DOE, and to receive confirmation that documents have been successfully transferred. So with the implementation of the DTS, a lot is staying the same, but there are some differences that we wanted to talk through. So first, what's staying the same is the roles and responsibilities of EI agency staff and service coordinators, as well as EI policies and procedural expectations. Additionally, NICE data entry and file upload protocols remain the same, as well as document storage policies and protocols. And then lastly, the DTS is an electronic replacement of the fax. So it's still, as I said earlier, a one-way transmission of documents. And once documents are sent, just as with the fax, they can't be retrieved or edited. Here's what some of the differences are. So obviously, the mechanism for transmitting documents is now electronic, which makes it more reliable and secure than the fax. Service coordinators now have to enter some metadata when they transfer documents to the new system. And with this metadata, the DOE now receives more information about children coming from EI. Another difference is that early referrals or referrals that are submitted earlier than 120 days prior to a child's first age eligibility are not accepted through the DTS. And then lastly, service coordinators can receive email confirmations about successful transmissions, and service coordinators must save and upload these into NICE. Next slide, please. So as we know, the system was just implemented in early August, so we wanted to share some early statistics with you all about how it's going. So during the training period of July and August this summer, we had over 260 designated DTS agency administrators participate in live trainings on maintaining agency information, and they also learned how to invite early intervention service coordinators and upload documents. A pre-recorded training was sent to all around 850 to 1,000 EI service coordinators across the city, and this is focused on maintaining their personal contact information in the system as well as uploading documents. As of earlier this week, as of October 14th, 114 agencies have created accounts to use the DTS system. And this includes 230 agency administrators. We have 149 active accounts and 81 pending. And then there are accounts now for 740 EI service coordinators, 677 active accounts, and 63 pending. An estimated just over 6,000 documents have been transmitted so far, including 993 notifications and about 1,500 referrals. We do want to note that this number is estimated because as we are still in an initial rollout period, some service coordinators have submitted documents in packets rather than as individual documents, which has disrupted the document count slightly. So I'll pause for questions on the DTS or our Citywide Information Dissemination or Transition Coordinator team before moving on.
This is Lydia. I just wanted to say that we're really happy to have seen this implementation happen and for the system to have become a reality. We have all talked for many years about the problems with faxing and losing faxes and having to refax. And so this system really takes care of that. I think we've been talking about the fax a lot today, and with Mary and with DOE and with everyone, and the fax is not our friend. I mean, I don't know. I mean, I've been saying it for 10 years, but I am really happy that, and so much about improving experience for families is about breaking down these silos. And these are silos that many times we're hostage to because we have to use the fax because we've never built another mechanism or anything like that. And I think that, you know, as time goes on and as we're willing to sort of do the work, and sometimes it involves additional consent or something else or entering a little bit of metadata, I think that it ultimately gets us to a point where the family's experience on the other end improves. And so I just want to say thank you to Caitlin. You have been personing the email box with a very small team and responding to service coordinators and to their supervisors about issues that they're having. And I think that this has really been a step in the right direction for both of our systems.
Thank you, Lydia. Agreed. And thanks to you and Nora for supporting communications and support to service coordinators and agency staff as well. So any other questions on the EI transition work? So with that, I'll move on to our general early childhood updates. And again, these are not unique to early childhood, but we'll be talking about these updates with the frame of early childhood. So next slide, please. So just as a reminder, I wanted to just share information on our preschool program reopening for this school year. This year, families had the option to select either a fully remote learning model or blended learning model, which consists of a mix of remote and in-person instruction. On September 16th, children who opted for full remote instruction began that instruction with their preschool program, and then children who opted for blended or in-person instruction at their preschool programs began on Monday, September 21st. I do want to note that some early childhood programs, such as our 4410 providers, family child care providers, and 3K and pre-K for all contracted community-based organizations, many of them opened earlier and were not bound to these opening dates. And additionally, some of these programs have opted actually to remain open for full-time in-person instruction. And then I did want to provide an update on our zone school closures. I will just preface by saying this information is rolling in. There's new information constantly rolling in, so this is subject to change at any moment. But anyway, out of an abundance of caution and to keep families and school staff safe, school buildings in the zip codes on the left-hand side of the screen, where there was a 3% or greater COVID infection rate, were closed as of Tuesday, October 6th, for at least a 2-week period. This means schools in these zip codes have transitioned to full remote instruction during this period. The governor's order extended school closures to specific geographies identified as the red and orange zones. Schools in the red and orange zones must close, while childcare may remain open, as this childcare is considered essential. I also do want to share that this order did not extend to our family child care providers. Given that, the DOEs were not compelling our contracted early childhood programs to close, and instead are giving them the option to go fully remote if they choose, but are asking that they notify us first. And again, the situation remains incredibly dynamic, and we expect to provide additional guidance in the coming days. So I'll pause for questions on those two items before we move to, before Avery provides us with some information on learning bridges. All right, Avery.
Hi, everybody. I hope your day is off to a good start. It's nice to speak with you all. So I've been working on our Learning Bridges initiative since just about August when we started getting things up and running, and I'm here to share some additional info with you all. So as you likely know, as we've begun to resume in-person schooling this fall in the city, many of the schools in our city are operating on a blended learning model in order to accommodate all of the children who have requested in-person services. So in order to help support families and children on the days when they are remote from their schools, we've opened Learning Bridges programs across the city. These provide free child care for children from 3K through 8th grade on the days they're scheduled for remote learning. These programs are operated by CBOs around the city. They're paired with specific schools in order to support the cohorting of children and limit overall everyone's exposure as a COVID-19 precaution. They provide children opportunities to connect with their remote learning activities. In K-8, there is, I would say, more focus on actually, completing, on the computer remote learning. And then in preschool, we focus more on in-person learning since we know that's how young children learn best. They also include scheduled time for art, recreation, other age-appropriate activities, and they follow all of the same health and safety precautions as our schools. Enrollment is and eligibility. So enrollment is open to students who are enrolled in blended learning at DOE schools and programs. So that includes district schools as well as pre-K and 3K programs that are operated by the DOE for children ages 3K through 8th grade. This includes District 75, 4410s, 853 programs, like I said, 3K, pre-K, early learn, DOE, elementary, and middle schools. So many, many different settings. In terms of placement, priority is given to children who are, most at risk during this time and communities most impacted by COVID-19. So these priority groups include families living in temporary housing, shelters, and hotels, children of DOE school and program staff, including staff of Learning Bridges sites or our other contracted early childhood providers like 3K, pre-K, and early learn. Families living in NYCHA developments, children in foster care or receiving child welfare services, children with disabilities, and children with parents who are essential workers or were previously enrolled in our RECs, which we're operating in the spring. These are the emergency educational settings set up during the height of the pandemic. So we've transitioned away from that setting and towards Learning Bridges. So I know that's a lot of info pretty quickly. If anyone has any questions, I'm happy to take them and respond where I can, and we'll follow up where I can't respond immediately.
I have a question. This is Lydia. Can you talk a little bit about pathways for accessing Learning Bridges?
Sure, yeah. There's a website that I can make sure is shared out with this group. It's on the DOE website. Families apply through the link on the Learning Bridges page. And then the process for basically opening Learning Bridges seats dictates availability to some extent. So what we've done is on that same page where the application link is, families can now see whether their school is paired with a specific Learning Bridges site. And the pairing of Learning Bridges with schools is focused on, the burden of COVID-19 in that community, the number of, families we anticipate fall into those priority groups. And so once a school is paired with a Learning Bridges site, we process enrollment offers, first to priority families and then opening up additional seats as needed.
Thank you.
Mm-hmm. Is there an additional cost to the parents?
It's completely free. So the services are provided from 8 a.m. to 3 p.m. and free of cost. Some programs might operate additional hours, either early drop-off or late pickup at an additional fee to families, but 8 a.m. to 3 p.m. is free. And that includes meals as well.
Does anyone have any other questions for Caitlin or Avery? Okay, well, thank you for joining us.
Thanks, everyone.
Thank you. And now we'll have reports from our LEICC committees. Do we have any of the committees who have reports?
I have a report.
Go ahead, Jeanette.
So as we've talked about in previous LEICC meetings, the academic partners and 6 EI provider agencies are working on a fieldwork manual that can be used for clinical supervision of graduate students during fieldwork or clinical placements with EI provider agencies. And this is a relatively new thing for early intervention because graduate students typically in the past worked in center-based programs with children 4 years and older. So this is a kind of exciting development to work on. The 6 academic partners are from 5 CUNY and 1 SUNY graduate program, from Brooklyn College, from Lehman, from Queens, from Hunter, and from SUNY Downstate. The 6 EI providers include Achieve Beyond, Challenge, Amelia's Kids, Happy Dragon, ICLC, and Strive Right. The group met remotely in June 2020 to determine what type of information should be part of the fieldwork manual. And the sections included policy and procedures, preparation and process for clinical fieldwork with the EI provider agencies, clinical supervision, and from theory to practice. So the 6 members of the group broke up into 4 different committees, and each one is responsible for writing a specific section. Our next steps are to put all these sections together by early 2021. And we're inviting EI provider agencies who would like to be part of this project or are interested in providing fieldwork placements to notify us at embeddedcoaching@health.nyc.gov. That's my report.
Thank you, Jenna. Do we have any other committees for reports? Okay. Okay, so at this time, we will have public comments. Do we have any public comments?
We did not receive any public comments.
Okay, so there are no public comments for the record. And I would like to say thank you, everyone, for participating in our meeting, and the LEICC meeting is now adjourned. Please stay safe and stay healthy, and we will see you next quarter. Thank you, everyone.
Thank you. All right.
Thank you.
Bye, everyone. Thank you for joining.
Bye.
Good to see you all.
Bye-bye.
Ended early, before 8 hours.